Hi everybody, and welcome to our module on general anesthesia. The word anesthesia means insensitivity to pain, and this is one of the main goals of anesthetic drugs, is to render a patient insensitive to pain so that you can perform surgery and do other things that otherwise would be very uncomfortable. So there are a couple of goals of anesthetic drugs. One is to produce loss of consciousness. Another is to produce analgesia so that the patient does not feel pain. A third one is to produce amnesia. We don't want people to remember things from surgical operations, so we want them to have amnesia for all the events that occurred while they were under anesthesia. And then finally, we want anesthetic drugs to produce muscle relaxation so we can position the patient as we need to for surgical operations. When people refer to general anesthesia, they usually mean inhaled and intravenous anesthetics. These are drugs that render patients unconscious. In this video, we'll focus on the inhaled anesthetics. In another video, I talk about intravenous general anesthetics. Besides the inhaled and intravenous anesthetics, there are some other classes of drugs that are used as part of anesthesia. One big group are the neuromuscular blockers. These are used to paralyze patients during surgical operations, and I have a separate video on neuromuscular blockers. And then the last group of anesthetics are local anesthetics. These are drugs like lidocaine that can be injected to numb the skin and provide local anesthesia to nerves in the periphery. In this video, I'm going to focus on the inhaled general anesthetics. And drugs that are inhaled anesthetics usually end in the word "ane," like desflurane, enflurane, or sevoflurane. One exception is nitrous oxide, which is a special inhaled general anesthetic that we'll talk about later in this video. And most inhaled general anesthetics derive from diethyl ether. Many years ago, people discovered that ether could put patients to sleep. Scientists then began modifying the molecule into modern anesthetics like isoflurane, which have the ether structure with other atoms added. In terms of clinical effects, there are two key properties that determine the effect of a general anesthetic. One is the blood solubility, the other is the lipid solubility, and we'll talk about these two things now. So the blood solubility of a gaseous anesthetic is what determines the onset and offset time of inhaled anesthetic drugs. And the idea here is that molecules of a gas that are dissolved in blood have no anesthetic effects, but molecules that are not dissolved in blood can produce an anesthetic effect through effects on the brain. Initially, when the gas gets into the bloodstream, it will be soaked up by the blood. You need to saturate the blood before undissolved gaseous molecules will start to accumulate, and it's those undissolved ones that can produce the clinical effects. So what this means is that if an anesthetic gas has a very high solubility in blood, it's going to take longer to have an effect because the blood is going to soak up lots of the gas molecules, and very few of them will be found in the gaseous form, undissolved in blood, where they can exert a clinical effect. So just to make this very clear, let's imagine that we have some blood here and we have a little bit of space for air above the blood, and we begin introducing anesthesia gas molecules from the lungs. Well, initially all the molecules are going to be soaked up by the blood, but if we keep pumping more molecules, the blood will eventually become saturated, and then we will start to get some undissolved molecules. And then if we keep pumping in anesthesia, we will get lots of undissolved molecules of anesthetic. The way we measure the undissolved gas molecules is by determining the partial pressure of the anesthetic gas. And so the partial pressure is only going to really begin to rise once you've fully saturated the blood. And that's why blood solubility is so important to the onset of action of gaseous anesthetics. So putting this all together, if an anesthetic gas has a high blood solubility, that means it has a higher tendency to stay in the blood, and it's going to take a longer time to saturate the blood so that the partial pressure will begin to rise. Clinically, this means that an anesthetic gas with a high blood solubility is going to have a slower induction time. It will take longer to induce anesthesia and put the patient to sleep, and also a slower washout time, because in order to put the patient to sleep, you have to put lots of gas molecules in the body, and it takes a long time for those to wash out. The opposite is true for anesthetic gases that have a low blood solubility. The blood can't hold many molecules of these gases, so the blood quickly becomes saturated with as much gas as it can hold. This leads to the partial pressure rising rapidly and quick effects being exerted on the brain. So drugs that are anesthetic gases with a low blood solubility have a shorter induction time, they more quickly put patients to sleep, and they also wash out faster. The way we measure the blood solubility of a gaseous anesthetic is by determining a number for that drug called the blood-gas partition coefficient. For example, for the inhaled anesthetic isoflurane, the blood-gas partition coefficient is 1.4. This means at any point in time there will be 1.4 molecules dissolved in blood for every one molecule that is in a gaseous form in the alveoli. Different inhaled anesthetics have different blood gas partition coefficients. Those that have a very high coefficient have high solubility in blood. And so as we just talked about, those drugs will take longer to induce anesthesia and also longer to wash out at the end of a case. Conversely, drugs with a low partition coefficient have low solubility in blood. These drugs will more quickly induce anesthesia and they more quickly will wash out of the body when you stop giving the drug. Shown on this slide is a table of blood gas partition coefficients for some inhaled anesthetics. Halothane has a very high blood gas partition coefficient. This means it has a high solubility in blood, and if you use halothane to induce anesthesia, it will take a long time. There will be slow induction. By the same logic, if you use halothane during an anesthesia case, it will take longer to wash out, and that's because of the high blood solubility. In contrast, nitrous oxide has a very low blood gas partition coefficient. This means its anesthetic effects are very quick in onset, and in addition, at the end of a case when you stop giving nitrous oxide, it will wash out very quickly as well, and this is all because of its low blood solubility. So back to this slide where we talked about how two key properties of an anesthetic gas determine its clinical effects. We just talked about the blood solubility, which determines the onset and offset time for a gaseous anesthetic. Now we're going to talk about the lipid solubility, which is very important because this determines the potency, and that lets you know what concentration of gas you should administer to the patient. So lipid solubility is the affinity of a gaseous anesthetic for lipids. The more lipid soluble a gas anesthetic is, the more easily it will diffuse into the brain, and therefore anesthetic gases with a high lipid affinity are more potent. This is sometimes called the Meyer-Overton rule, named for the people who first described it. So let's imagine an anesthesiologist is putting a patient to sleep for surgery. Anesthesiologists can control the concentration of gas that the patient inhales. So an anesthesiologist could administer 5% of an inhaled anesthetic to a patient, or the anesthesiologist could administer 50% to the patient. If the inhaled anesthetic is very potent, then 5% may be enough to put the patient to sleep, and 50% could be so much that it kills the patient. On the other hand, if the gaseous anesthetic is not very potent, then 5% may have no effect at all, and you may need 50% just to put the patient to sleep. So this concept of potency is very useful clinically because it tells us what percentage of gas to administer to the patient so they will go to sleep. And potency is related to the lipid solubility of a gaseous drug. So as I said, when you have a high lipid affinity of a gas, it's more potent, and that means that a lower gas concentration will be required to produce an anesthetic effect. And one of the ways we describe the lipid solubility of various gaseous anesthetics is by what's known as the oil-gas partition coefficient. Shown on this slide is a table with the oil-gas partition coefficients for some inhaled anesthetics. So halothane has a very high oil-gas partition coefficient. This means it's very potent, so you will need a low concentration of halothane in order to put a patient to sleep. In contrast, nitrous oxide has a very low oil-gas partition coefficient. So you will need a very high concentration of nitrous oxide in order to put a patient to sleep. And so this is how the oil-gas partition coefficient helps us understand the various potency of different gaseous anesthetics. Now lipid solubility is nice for describing potency, but as I was telling you earlier, anesthesiologists can control the concentration of gas that the patient inhales. So really what we want to know is not the lipid solubility, but the minimum concentration that we need to use in order to put the patient to sleep. And for this, we use a different measurement of gas potency called the minimum alveolar concentration. The minimum alveolar concentration, or the MAC, is a concentration of gas like 1% or 5% or 10%, and it's the concentration that will prevent movement in 50%